Hello, I'm Jerry Spivak to those people who do not know me. And these are my disclosures for my talk today. I apologize that I cannot be there in presence, and it's something I look forward to since the COVID-19 pandemic shut down full audiences. So we'll have to go without my presence. And I'm going to talk today about managing myelofibrosis in quotes because it's going to be a little different than you've heard before. In 2023, I've left my email address here, which are my initials and my last name at jhmi.edu for any questions that you might have in my absence, or if you want to take time and look at my slide set more closely. I have some comments here made by patients that I won't have time to go through individually, which talk about having both thrombocytosis and erythrocytosis, and what's the story with that, how one should be treated, what's the standard hematocrit in a woman. And the reason all this is going on is because the World Health Organization's diagnostic criteria for polycythemia vera are incorrect. And if you can't diagnose polycythemia vera, you can't diagnose any other myeloproliferative disorder. Physicians are having a similar problem because if the blood shows erythrocytosis and thrombocytosis, what do you really have? Because the World Health Organization thinks polycythemia vera is actually monocythemic when it has more than erythrocytosis. It has thrombocytosis and leukocytosis as well. So these are common problems, not only that patients experience, but physicians who are well-intended experience as well. And there are some physicians who, for example, I asked my patient in Santander, Spain, to get a JAK2 quantitative allele burden, and he told her that that's research and not clinical, and unfortunately it's very much clinical. And there are some physicians who think that polycythemia vera and ET are related, when of course they are not. And of course, here's the unfortunate criteria for polycythemia vera, which fail to remember leukocyte platelet counts and splenomegaly, and quantitative JAK2 allele burden as well. So let's go on quickly to a hematopoietic glossary. Hematopoiesis is blood production by stem cells. There are 200,000 stem cells in the body, and these cells alone are capable of both self-renewal as producing the blood cells that we need in the bloodstream. A clone is the progeny of a single stem cell because each stem cell is genetically distinct from the others. Thus, although hematopoiesis is monoclonal in each stem cell, because there's many stem cells, hematopoiesis is polyclonal. Clonal dominance, I'll show you an example of that. Genotype is the unique composition of a cell or a person. The phenotype are the observable features characteristic of a cell or a person. And penetrance, most importantly, is what the body allows us to see phenotypically in a single individual. And phenotypic mimicry is when two different MPNs with a similar genotype mimic each other's appearance. So to go on with that, here's a cartoon of chromosome 9, and on the P arm, on one side of the centrosome, which is in green, JAK2 is expressed. And this little cartoon shows you how you get from heterozygosity, one allele having the mutation and the other normal, and by a series of acrobatic changes, you can end up with homozygosity. And it's here that the stem cell can outproduce other stem cells. And this is the representative cartoon of the thrombopoietin receptor gene, MPL, which we'll talk more about. And I've just shown up here at this end of the gene the expression of thrombopoietin receptor is depressed as it is down in this end when there are mutations on this side. This is the transmembrane domain. So these proteins are abnormal inside a cell, and all these proteins are abnormal outside the cell. I've pointed out this protein in which genetically lysine has been changed for asparagine at amino acid 39. It's down here. This one little change. This is what is seen in the mouse. This is what normally is seen in the humans. If humans have this change that's in the mouse, what you find out is that they have actually thrombocytosis. And this is the same thing in an Arab population. Next slide. And this is all the chromosomes in the body, the somatic as well as the sex chromosomes. And here's chromosome 9. This is a combination of mutations in 321 MPN patients. And you can see how many of them have mutations or duplications of JAK2 in chromosome 9 and mutations or duplications, say, in chromosome 1 in these patients. So that MPN genotypes are complex. And this just shows how one stem cell randomly acquires homozygosity for, say, JAK2, and then it can outmultiply the normal stem cells. So at the end of the day, you get clonal dominance. So summing that all up, here are the patient's DNA mutation, that's the disease genotype, mixed with the patient's DNA, and that's the patient genotype. And what comes out is based on penetrance, and this is the disease phenotype. So every patient with an MPN driver mutation will import unique features to their NPN. And if we look at myelofibrosis of the 3 myeloproliferative neoplasms, they're clonal stem cells disorders. The clonal dominance occurs to varying degrees over normal stem cells. These are gain of function mutations, so you have increased blood cells, or they can be decreased without a definable cause in myelofibrosis. But these cells are functionally normal. Blood can be made outside of the bone marrow. That's myeloid metaplasia. There is this phenotypic mimicry between this NPN themselves and other blood disorders. There's no specific diagnostic markers for the NPN, and they're resistant to chemotherapy or radiation. Now, these are the distribution of the gain of function driver mutations in the MPN. And here we see that one mutation gives rise to 3 different MPN, and a single NPN can give rise to 2 different NPN. I need to point out these mutations are not mutually exclusive. They can exist with ABL, which is the mutation for chronic myelogenous leukemia. They can occur at a low expression, which we call CHIP, and I'll get back to. And the quantitation of the driver mutation allele is mandatory for diagnosis. So here are the factors. This is the penetrance that add up with the mutation to give us a phenotype. And there are many things here, and we'll talk about each of them as we get along. So here is the association between sex, disease duration, genotype, allele burden, and NPN type. ET, PV, PMF, please note here, there's nothing up here because if you have less than 50% JAK2 allele burden, you are heterozygous and not dominant. Whereas you can see here, Most patients are dominant, but some stay undominant for many years. And here is PMF, and you can see there are just a few patients that aren't dominant, but everyone else is dominant from the beginning. And what this says, these patients here, we'll talk about them, they have unique, what we call cytopenic myelofibrosis. Now, this is just to show you a pretty picture. Here's your stem cell giving rise to lymphoid stem cells, and here giving rise to megakaryocytes, erythroid cells, mast cells, myeloblasts. So you can see all the cells coming from a single cell. At the same time, we can make this picture a little more complex. Here's a long-term stem cell. Here's a mutation. It's transmitted everywhere. Lymphocytes, myeloid cells. Up here, stem cell behavior is really myeloaccumulative, and interferon and ruxolitinib act here. And down here, you see all the growth in the peripheral blood cells. And down here, ruxolitinib and hydroxyurea act here. Of course, interferon will as well because it's acting back here. But what you get the picture here is that polycythemia is the ultimate phenotypic complex of the JAK2 mutation. And if we see cells with that mutation, we have to think polycythemia vera first. But here's a little wrinkle that isn't seen before. And this shows that not only is this stem cell able to give rise to other stem cells, but there's a megakaryocyte repopulating cell, which the stem cell needs to stay quiescent in its marrow niche. There's a myeloid erythroid stem cell, and there's a common myeloid stem cell. So out of this, you get thrombocytosis. Out of these, you get polycythemia vera and primary myelofibrosis. And note that each of the cells here, even though they have the mutation, are sensitive to these growth factors for these receptors. Now, what is what I call anticipation of myeloproliferative neoplasms? Many cells start out so-called essential thrombocytosis, but some of them in women go to polycythemia vera. Some of them, mostly in men, go to primary myelofibrosis. And some of the vera cells also go to primary myelofibrosis, and some of the myelofibrosis patients go in the other direction. So polycythemia vera is the ultimate expression of the JAK2 mutation. Now, I don't have time to talk about the explanation for essential thrombocytosis going to myelofibrosis and polycythemia vera, but possibilities are clonal succession, clonal expansion due to duplication of JAK2 V617F, some sex-specific evolution of ET to PV or MF, and finally plasma biome expansion masking the increased red cell mass. This is called phenotypic mimicry. And here you can see a patient in the year 2000 who has essential thrombocytosis in a man, unusual. And you can see his JAK2, when we could measure it, allele burden was very low, less than 50%. And you can see his amount of receptor expression, a protein analysis was 57. But as his JAK2 allele burden goes up, his MPN expression goes down, he develops polycythemia vera. And here's a woman with a 17-year history of myelofibrosis whose spleen was taken out, and she was on hydroxyurea, and her hematocrit rose after 17 years, and now she has polycythemia vera. So this is the clinical behavior of both JAK2 and calreticulin essential thrombocytosis. They start out, and after about 15 to 20 or more years, this ET has mutated to PV. So this was in women. And here's myelofibrotic transformation, which is primarily in men. And here's the ET. And here's CalR. And here's polycythemia vera developing myelofibrosis. But please look at the year. This is year 25. This is much earlier, generally between years 5 and 12. Now, I list on this slide all the causes of myelofibrosis, and you can see the MPN in brackets, but there are also non-malignant causes. And here, just for your viewing, is what I would say is probably stage 3 or 4. And these black fibers in here, which are stained with silver, and see, are the myelofibrosis. These circles are actually adipocytes in the bone marrow. And you'll be able to see in another slide that these are megakaryocytes that are hanging around. So here's a grading scheme for reticulum, which you may hear from your hematologist or oncologist. Here's grade 1, which is pretty close to grade 0. There are faint strands that you can see of reticulum. Also these megakaryocytes. Here it's much easier to see the reticulum. And this is grade 2. Here's grade 3. Again, many megakaryocytes, which are responsible for this fibrous network. And here's grade 4. Today, pathologists are using grade 0 to 3. And you can see here, there are branched but bundles of these gold-stained, silver-stained reticulum. Now, here's an interesting study where someone looked at reticulum expression in normal individuals. And here's 2 different studies using different criteria, but you can see that normally up to 20%, or in this case 27% of patients, have grade 1, and they don't have, and they're otherwise healthy. And none of them have grade 3 or 4, but some of them have grades 2. And here's, say, grade 4 myelofibrosis in a group of patients who had from 1 to 5 grades of myelofibrosis. And you can see that the production of red cells by hemoglobin, hematocrit, or the number of red cell count is unchanged regardless of the degree of fibrosis. So fibrosis does not mean that bone marrow production of red cells is shut down. Now, I've talked about phenotypic mimicry, and here's a nice example in nature. Here's the coral snake, the most vicious, deadly snake poisonous snake in the United States. And here's another snake which is tired of being eaten because it looks like a coral snake, or killed because it looks like a coral snake. It's actually decided to become a coral snake, so everyone will leave it alone. That's phenotypic mimicry. So here's an important issue of that. Here's what is called primary, you may hear this, fibrotic change, pre-MF, and here is MF. And this is only grades 2 or 3. So unlikely to be this for normal marrow, but here, less than grade 2, are patients thought to have pre-fibrotic myelofibrosis. And note that you can't have any of the other diseases, but if you can't diagnose PV correctly, you're going to get in trouble here. And it's recommended to use highly sensitive assays, less than 1%, where you'll get normal patients who look like this, when those are people you're not interested in. So let's see what's going on here. So this is in the supplement of the articles, these data, so that normally most people won't read the supplement, they'll just read the article. And here's supposedly patients with W World Health Organization ET, and here's early myelofibrosis. And what you see here is that the range of hemoglobins exceed the 16 grams required for polycythemia vera. And you see this in the same thing in early PMF. So what you see, there is no difference between these two. And the reason there's no difference is because they actually have polycythemia vera. And if we want to look at this point here as patients with myelofibrosis who over 25 years do not have myelofibrosis, if they have less than 50% JAK2 allele burdens, and if you don't, then you gradually, over the same period of time, have myelofibrosis. But it doesn't really seem to affect survival. So that's why I thought this slide of new Chicken Little, I put reticulum grade here and the risk of the sky falling. Myelofibrosis, I do not believe can be considered as a truly adverse histology in bone marrows because it does not prevent blood production. And more to the point that bone marrow pathology in ET is unreliable for determining disease subtypes. So myelofibrosis is difficult to apply reproducibly in describing the true ET from pre-fibrotic myelofibrosis. There are other things that are elevated in primary myelofibrosis, and that is circulating stem cells. And when compared to polycythemia vera, they're up approximately 3 times normal. And even when there's been a splenectomy, they're still much higher than they would be in P. vera. So this is something that you can actually measure in the peripheral blood. And myelofibrosis equal or greater than grade 1 does not impact survival in patients with polycythemia vera. Now, you will read in the literature that there are low risk and high risk PV patients. And where does this come from? Well, it was in an Insight advertisement, and it comes from this article, which has been repeated for the last 10 years. And you get CME credits if you actually read it. Unfortunately, this is a slide from Dr. Silver's lab, which shows that myelofibrosis occurs in both low and high risk polycythemia patients. And this shows it again from Dr. Silver's laboratory. And I'm not sure if this is ours or another laboratory, but there are at least 6 studies that shows that age cannot be used for risk stratification in polycythemia vera. Now, I don't mean to downplay the significance of complications in primary myelofibrosis. There are many, and this is a serious disease. And the reason there are many is because of all the mutations are acquired in this disease, and this just slide shows these. And if there is no adverse variance, survival is still reduced to 8.5 years. But once you have 1 or 2, survival becomes increasingly more constricted. And why is that happening? Well, it's because during our lifespan, normally we acquire, and this is just part of a group of mutations, which increase over lifespan. JAK2 is one of them. You can have a JAK2 mutation and polycythemia vera coming out of the birth canal, or if you're a woman, you can have polycythemia vera at less than age 40. But you notice that these mutations increase. Some of them are myelodysplasia. Some of them are other mutations which have their own deleterious effects on the genotype of the patient. And you'll notice here that you hear a talk in the main symposium by Dr. Stevesa, who was responsible for recognizing this situation, where you will get what are called mosaics, less than 2% allele burdens, which gradually increase after age 60. And you'll see it's in here that you start to get this small increase in acute leukemia. So these are processes that go on all of our lives. And the end result is those patients who have primary myelofibrosis have this sort of probability, low risk, slightly higher risk. These are the intermediate twos, and they're the real high risk. And you can see at the 50% allele burden, how restricted their lifespan is. But if we look over here at primary myelofibrosis occurring in patients with polycythemia vera, if there are no risk factors, then there's no decrease in survival. And if there's one risk factor, again, that's important, and that's anemia. But if there are more risk factors, then you have the same problem that you have in polycythemia vera. Now, if you're a physician and are unfortunate enough to have a patient so-called lower risk myelofibrosis, this is what the NCCN would like you to use to treat patients. And I shudder here that someone's going to use hydroxyurea for cytoreduction when ruxolitinib is certainly welcome to that task. And now we have 4 compounds. I don't have enough time to tell you about them, but you can take these compounds, particularly ruxolitinib, and extend the lifespan of patients. And I'll talk more about that on Thursday alone. Or you can use interferon here, but hydroxyurea should never be used. And the poor physician that has to go through all this is going to make it difficult to decide exactly what to do. And of course, things are not better in higher risk disease, but certainly these patients now have 4 JAK2 inhibitors to treat patients with. And here's again is another scheme in terms of bone marrow transplant that one can use. And here's what I mentioned before. Unfortunately, ruxolitinib is associated with RAS mutations. But if you don't get a RAS mutation, you can have a very long survival and actually a molecular inhibition similar to interferon. These other tyrosine kinase inhibitors tend to have FLT3 inhibition, which is associated with gastrointestinal side effects. So let me stop here with pegylated interferon and how it affects early stage primary myelofibrosis. You can see the leukemia-free survival and the overall survival in many of these patients is not reached who get this effect from this treatment, which we should be introducing earlier than later. So let me summarize here that accurate diagnosis is essential because post-PV MF is different than that of primary myelofibrosis. That NGS mutation analysis and cytogenesis analysis is critical in risk prognostication, and age is certainly not such a thing except for age-related infirmities. Low-risk patients can benefit from pegylated interferon or prolonged TKI therapy. High-risk patients under the age of 45 should consider marrow transplantation if a donor is available. And symptomatic anemia resistant to an TKI may respond to another TKI or a variety of other treatments. Radiation can be used to control splenic enlargement or portal pulmonary hypertension. Again, there are multiple TKIs. Splenectomy is only palliative, but if very large may be helpful for early response to bone marrow transplantation. And with that, I will stop. Unfortunately, I cannot take your questions, but I can by email. Thank you.
Great. I'd like to thank Dr. Spivak for putting this together with Chad, this video presentation last minute.